Modern healthcare systems feed artificial intelligence billions of individual clinical data points every single second of the day. But look at the outputs being generated by this exact same model. For a single patient, it asserts with 99% confidence that they have diabetes. Simultaneously, it states they have prediabetes. A third output registers no diagnosis at all. Hospitals and clinics are deploying these advanced machine learning models to solve systemic inefficiencies. Yet in practice, these systems frequently produce conflicting clinical recommendations and accelerate administrative waste. This contradiction is not a result of insufficient computing power. It is not caused by outdated algorithms or poorly coded software. These failures suggest the problem isn't the software, but the architecture beneath it. We refer to this as the invisible collapse. It is a fundamental architectural failure existing beneath nearly all modern healthcare workflows, quietly sabotaging operations. To understand why this happens, consider how traditional IT operates. Traditional software executes rigid rules within a closed environment. It does exactly what it is told. But AI functions entirely differently. It learns by actively recognizing complex patterns directly from the existing data it is fed. If the underlying data architecture is structurally fragmented, the AI system simply learns, models, and scales that fragmented reality. When AI is deployed into a broken data foundation, it confidently inherits and amplifies every invisible error hidden in the system. This network map displays healthcare IT's historical design. Systems were built to serve individual corporate entities, hospitals, labs, insurers, rather than supporting a continuous patient journey. Because of this legacy design, each organization stores only a narrow fraction of a patient's medical story. When an organization purchases an AI model, they drop it directly into their specific, walled-off database. Operating inside this isolated system, the AI only knows what it can access locally. It is entirely blind to the outside network. If a patient's lab results exist in the independent lab system and their medication history is stored at Hospital B, the AI in Hospital A cannot see them. It makes decisions without critical context. This structural blindness directly results in outputs that project a dangerous, false sense of confidence based on incomplete clinical facts. This disconnect is even more severe when we look at administrative workflows. Here we see the strict firewall between provider information systems on the left and payer systems on the right. As a single patient encounter crosses this divide, the record is routinely duplicated and altered. One version enters the clinical side, a slightly modified version enters the billing side. AI models cannot distinguish clinical truth from duplicate records or inconsistent coding. They treat all text as fact. When an AI tool attempts to reconcile these altered records for a standard process, the data mismatches. The system rejects the request. These automated system failures directly accelerate administrative waste, driving up claim denials, triggering endless appeals, and exhausting healthcare providers. Without a shared data architecture uniting clinical and administrative workflows, deploying AI actively worsens the exact inefficiencies it was purchased to solve. To correct this, the legacy organization-centric data models must be dismantled entirely. We have to introduce a new foundational structure, organizing all data around a single longitudinal timeline mapping the patient's entire journey. This structure is known as a patient-centered data architecture. The core architectural question shifts. Instead of asking which hospital owns this data, the architecture asks what information is needed to care for this patient. Organizing data longitudinally across time and care settings is the strict prerequisite for AI to evaluate the whole patient rather than isolated fragments. However, physically organizing data along a timeline is insufficient if the disparate systems contributing that data do not share the same meaning. This requires semantic interoperability. Watch as standards like ICD-10, SNOMED-CT, and HL7 FHIR snap into place, bridging the data nodes. These standards act as a unified language. They allow an AI to reliably compare, compute, and reason across previously incompatible datasets. Once the data shares a unified language, the historic, rigid barrier between clinical and administrative intelligence systems can finally dissolve. Diagnosis, treatment plans, and billing codes all draw from this exact same unified data well. Achieving semantic interoperability prevents conflicting AI interpretations and eliminates redundant administrative work. When you scale this architecture from a single patient timeline to the integration of the entire healthcare ecosystem, you create a massive, unified network. This unified model is the realization of the Comprehensive Logistics for Automated Decision Support Framework, or CLADS. Within the CLADS architecture, AI ceases to be an isolated application. It becomes an embedded, system-wide intelligence layer. But the quality of this overarching intelligence depends entirely on continuous, rigorous data governance. The system requires constant oversight tasks, validating data integrity, monitoring the network for bias, and continuously auditing the AI's recommendations. Strict, continuous governance transforms raw, disparate data into a trustworthy asset capable of safely powering national-scale AI. Clinicians require the reasoning behind an AI recommendation to make an informed decision. As you can see in this interface, modern AI must be able to answer specific questions transparently. Why was this recommendation made? Which data sources were used? What context is missing? This level of architectural explainability is the prerequisite for widespread clinician adoption and restoring trust across the healthcare system. Artificial intelligence is merely a reflection of its environment. It cannot fix a broken foundation. By abandoning silos and establishing a patient-centered, well-governed CLADS ecosystem, healthcare transforms AI into a trusted partner in equitable care delivery.